great pleasure to introduce to you Dr. Lawrence Mbuagbaw, who's the first winner of the Dave Sackett Doctoral Scholarship Award. This is an award that was established at the first Sackett Symposium, and the one message I have about the award is that additional donations to help support this award would be most welcome. Lawrence is a public health physician who trained at the University of Yaoundé in Cameroon and at the Hebrew University of Jerusalem, and he's currently a PhD candidate in the Health Research Methodology program at McMaster University. His research involves using text messaging to improve adherence to antiretroviral therapy. Lawrence?
Thanks, Andy, for the introduction. My name is Lawrence Mbuagbaw. Usually when I TA, I quiz students on how to pronounce my last name. I know many people who have that last name who can't pronounce it, like my daughters, so. Today I'm going to talk about text messaging to improve adherence to antiretroviral therapy, and clearly from, please can you reset it? Yeah. Thank you very much. Yeah. Clearly from the title of my talk, you can see that if I was to pick between RCTs and observational studies, I either pick both or none, because I feel they should go hand in hand. I have no potential for conflict of interest, mostly because I'm too young. So this is what I have to talk about today. Interestingly, nobody told me what I was supposed to talk about. I'm a PhD student, and technically they just send us out and say, okay, you go and talk about this. But for this symposium, nobody said what I should talk about. They just said, come and talk. So I'm going to talk about Dave Sackett. I'm going to talk about my supervisor, Dr. Lehana Tabane, and then I'll give you a little background on the kind of research I'm doing and exactly how an RCT project turned into multiple observational studies and eventually a meta-analysis. Just one word about Dave Sackett. He's an inspiration to us all. I believe he's the teacher to almost everybody here, and that's exactly what I think about him. He's an inspiration. But most of my success for the past few years has been thanks to my supervisor, Dr. Lehana Tabane. He makes me feel like a soldier because wherever he leads, I want to follow. Now, to the matter at hand. Currently worldwide, close to 30 million people are living with HIV. But HIV is no longer the horrible disease it used to be. Outcomes have improved greatly thanks to the advent of antiretroviral therapy. But like every other pharmaceutical product, it only works well if you actually take it like it's prescribed. If you don't take antiretroviral therapy as is prescribed, the rates of mortality increase. There's a lot of morbidity. You're more likely to transmit the disease to other people. You also develop resistant strains. And finally, all of this accrues into increased healthcare costs. So what we are saying is we need to find innovative strategies to get people to take their medication as is prescribed, especially with regards to antiretroviral therapy. In recent years, text messaging has developed as an adherence enhancement device, mostly because of its widespread use, and it's also extremely cheap. Is there anybody here who does not have a mobile device? Nobody. So I can all text all of you and remind you to fill your evaluation forms, and that will be an effective intervention. That's why the whole of this thing came up. So with CAMS, CAMS is the acronym for the Cameroon Mobile Phone SMS Trial, and what we were planning to do was to randomize people to two groups. The control group will receive usual care, and the intervention group will receive weekly motivational text messages. And what we call motivational is a sort of message which we developed based on the held belief theory of behavior change, which requires that the message be contemporary, be motivational, and empathic. So we'd have messages like, we know it's hard, remember to take your medication. Your family cares about you, remember to take your medication. Or even Merry Christmas, remember to take your medication. So we put up a really fancy poster with an iPhone, which we used to attract people into our trial. So some of them saw this poster and they actually came and requested to enroll in the trial. And we enrolled up to 200 people. This is an overview of what happened with the CAMS trial. We planned to conduct an RCT, but then before we started the RCT, we realized this was a novel intervention, text messaging. We have no idea what it's about and how it's going to work. How many messages should you send? At what time of the day should you send them? Do people even want to receive text messages? What exactly should the content be? Who should the message come from? Should it come from the doctor? Should it come from Barack Obama? Should it come from a movie star? We needed ideas. So before conducting the RCT, we had to go a step backwards and initiate a qualitative study. And then during the RCT as well, we used our baseline data to conduct an observational study. After the RCT, we did more observational studies. And along the line, we conducted an individual patient data meta-analysis and also a mixed method study. And then we'll be moving forward to a concept paper. So this is what my PhD thesis is about, actually. So that's a brief overview. And I'll look at each of these studies in details and tell you the key messages that we got from them and why I think RCTs and observational studies should be put together. The qualitative study was entitled Considerations in Using Text Messages to Improve Adherence to Highly Antiretroviral Therapy. The key findings were as follows. People thought it was a good idea. They wanted to receive text messages, but they had issues regarding privacy. You don't want a text message that comes in and says, hey, remember to take your antiretroviral therapy. And then somebody who didn't know that you had HIV suddenly realizes that you have HIV. So the messages automatically should not disclose your status. They have to be coded in some way. And then we also asked them, we sort of used the theories of health promotion to find out exactly what the people who took antiretroviral therapy correctly, what motivated them to take their treatment. And we tried to build on that to motivate the others. So some people said, well, they want to see their kids grow up, so that's why they take their medication so they can live longer. And we built on these factors, these motivational factors, which we identified in the qualitative study, and we integrated all of these into our trial. Now, surprise, surprise, we ran the RCT, and 6 months later, we found out that motivational weekly text messages do not improve adherence after 6 months in experienced patients. Despite all the qualitative data that we got, we came out with something that many people here will call a negative study. If we wanted to bend the rules, we could have made it a positive study by reducing the threshold of adherence from 95 to 90. We would have had a positive study, but then we published our protocol, so we couldn't cheat anymore. But we found out exactly what we did wrong by looking at all the other RCTs that have been conducted in this same field. The first thing is that 6 months is just too short to figure out exactly what's going on. After 12 months, that's when you get a significant effect. And also, we wanted to have a baseline measure for adherence, so we got treatment experienced patients. But unfortunately, once patients are already experienced in taking antiretroviral therapy, they are also experienced in their bad habits of non-adherence. So that is extremely difficult to change. All the successful trials took patients who were initiating antiretroviral therapy. So that we learned after we had analyzed our data and we looked at the other studies. At the beginning of the study, after collecting the baseline data, we started looking at the factors that were associated with adherence. And we found out that multiple reminder methods improve adherence fivefold. So it's not only about sending a text message, it's about having multiple different kinds of reminders. And we had a full panoply of reminders that people cited. Some people use soap operas to remind them to take their medication. Some people use prayer time. Some people had personal reminders. Somebody would walk up to them and tell them to take their medication. Some people had their own text messages that they had family members send to them. So now we are learning that no matter how effective the text message is, you still have to add something alongside. This is also a part of the same study. We decided to look at exactly what the relationship between adherence to antiretroviral therapy and cost of medication was in Cameroon. So cost of medication has dropped from about $128 per month to almost zero between 2000 and 2010. And adherence rates in the red line have consistently been going up, irrespective of the study design, irrespective of how adherence was measured. It has been going up consistently. So this gives us the idea that even if we are providing text messages to improve adherence, if the medication is expensive, people will not take it. And the problem with the kind of suboptimal adherence you have here is a kind which is extremely difficult to measure, because if you ask them if they have taken their pills, they would say yes. But what they have done is they have broken the pills in half and spaced them out. So the medication for 1 month would last for 2 or 3 months. So they still have medication, but they are not adhering to treatment as it is prescribed. At the end of the trial, we interviewed people from the intervention arm to see what their responses were, because our messages were interactive, so they could call back, they could text back, they could ask us for help, it was very interactive. So we found out, in short, that patients really wanted to be able to talk back to us, and they had other issues they wanted to address. They wanted to be able to change their appointment dates, for example. They wanted medical counseling. Some of them wanted us to talk to their spouses and partners to convince them to take HIV tests. So this is actually information that we got from an observational study, which shows us how important the interactive component of the message is, which we didn't identify in any trial, and which we subsequently introduced into the individual patient data meta-analysis. And we found that interactivity is key in the efficacy of text messaging. So this is the protocol for the individual patient data meta-analysis. We've completed the paper and we have submitted it, and we are waiting for feedback from so what I tell you here, don't tell anybody. We know what works now. Text messaging should be weekly. If you send the text messages daily, people don't like them. They are annoying when they are daily. They should be weekly. They should also be short. No long messages, no long stories. Just remember to take your medication, or call to order, or how are you? As soon as they see the number that sends the text message, they get the reminder and they use it. And they also want the text messages to be interactive. They have to be able to reach back to you, otherwise it gets automated and it's a little impersonal. And finally, the text messages seem to be more effective in people who have at least a primary education. In almost all the trials, education showed up as a potential predictor of efficacy of text messaging, and also a significant subgroup effect. Now we are moving forward with this. We are trying to see if it is possible for the communities to own the text messaging program. And this, I feel, is an important bridge between RCTs and observational studies, because we started off with an intervention. But if we move towards community ownership of a text messaging project, the community members design, initiate, and send out their own text messages themselves. Then it no longer becomes an intervention, because we are not experimenting, we are not doing anything. Any further data we collect beyond this point becomes observational. So this is an important bridge between RCTs and observational studies. So I actually started analyzing the data from this mixed methods study a few days ago, and what's coming out is that the communities are ready and willing to run a text messaging program on their own. So it no longer needs to be an intervention which is monopolized by the health system. Just teach them what to do and let them run it themselves. So moving forward, our concept paper will be looking at how much of this technology we can move to other chronic diseases. The idea arises from the fact that we all know that resources are limited for research, and after all the work that has been done on text messaging for HIV, a lot of people want to know whether text messaging works for diabetes, for hypertension, for cancer, for asthma, and many other conditions. Should we repeat all of this research? I don't know. I don't think so. How much of this can we transfer to other chronic conditions, and exactly how are we going to apply it once we transfer it? My take-home message is as follows. Complex questions require complex methodologies. We just can't use an RCT or an observational study to answer the kinds of research questions that we have. Not every intervention is about a medication for which you need the rigor of an RCT. So RCTs and observational studies can and should be friends, and they should go hand in hand. They should date, and they should get married, and should have kids. I would like to acknowledge the help of the Yaoundé Central Hospital, the Center for Development of Best Practices in Health. The RCT was run as my postdoc fellowship with the Canadian HIV Trials Network, and I would also like to acknowledge the assistance I have had from McMaster University through the Department of Clinical Epidemiology and Biostatistics. Thanks for your kind attention.